All right, so this is going to be the part one lecture video for chapter 7. Chapter 7 starts to go into psychiatric and related drugs, so drugs that we use for different types of psychiatric disorders, mental illness, and things like that. So, and chapter 7 starts out, you're going to start reviewing from slide 5 of your PowerPoint. And with this, it starts out with talking about depression. So depression is feeling of pessimism, worry, intense sadness, loss of concentration, slowing of mental processes. It can also involve problems eating or sleeping. Mania is mood of extreme excitement, excessive elation, hyperactivity, agitation, and increased psychomotor activity. Bipolar is characterized by mood swings that alternate between periods of major depression and periods of mild to severe chronic agitation. Post-traumatic stress disorder, known as PTSD, is persistent anxiety or the recurrent fear after a terrifying event. So a couple little interesting facts. So PTSD was first recognized in World War I for combat veterans. However, at that time, it was not referred to as PTSD. It was actually called shell shock. PTSD has since emerged as a major civilian illness, especially after the Iraq War and then also Hurricane Katrina. So the important thing is a lot of people think PTSD is just a condition that affects our military personnel, and although that is a large population of that for good reason, that's not necessarily true. I mean, everyday individuals experience some level of trauma or traumatic experiences in their lives, and they can suffer from PTSD. I have a really close family friend who he was the godfather of my daughter, 37 years old, passed away this February. So it's been a little over 2 months now. And he died at home. And the family was trying to resuscitate him. And so they are going through this PTSD situation for themselves. And they weren't in the war, but they had a traumatic event happen to them, and they're all kind of suffering from those consequences even a couple months later. Not just the loss and the grieving process, but from the actual events that took place that day. So PTSD is a huge thing. It's something that has been on the focus of our mental health campaigns and our mental health organizations all across the United States. So going back to bipolar and disorders and depression, typically those are handled with the prescribing of different antidepressants. And the important thing that people have to understand, and again, this counseling comes from the pharmacists themselves, is that for most people, it can take about a good solid 4 weeks for these drugs to actually start taking their full effect. So that's one thing that's important to be communicated to our patients in the counseling process, especially if it is a first time or a new prescription that they're taking for depression, is them understanding that it's not a magic pill. It's not going to work overnight. So seasonal affective disorder is a depression that occurs in the fall and winter and then remits in the spring and the summer. So this is very common in certain geographical locations in the United States. So, in Arizona, we're pretty lucky to have, pretty mild winters. We do have some extreme heat in the summer, but, we don't get gobs amount of rain like, the Northwest area, Oregon and Washington in the Northwest. And we don't get the 6, 8 plus feet of snow, and these horrible blizzards and these horrible snowstorms that, you get stuck in your house and you can't leave and it's cold and, everything is white and covered and, it brings about the seasonal affective disorder where people tend to get depressed in these times. Also around the holidays, not everyone has family members, and everyone's situation is unique and different. And sometimes around the holidays, people who are lonely or people who have lost loved ones during that time can get that depression setting in during those holiday months as well. So neurotransmitters play a huge role in depression and other mental health disorders. Neurotransmitter is a chemical that is produced by a nerve cell. We kind of covered that a little bit in chapter 6, which is involved with transmitting information throughout the body. So some of these neurotransmitters, again, include serotonin, norepinephrine, and dopamine. Serotonin is one of the biggest ones that is directly related to depression. Antidepressants do have a delay of onset from 10 to 21 days, and antidepressants are never going to be described as an as needed basis. Again, they're not going to be prescribed of, if you're not feeling very well and you're feeling pretty sad today, take one of these. No, this is something they have to consistently take pretty much for the rest of their lives. In some sort of fashion, some form or fashion, because that's how these medications are designed to work. So the medication guide is dispensed every time an antidepressant is dispensed, and the reason for that is because of the increased risk of suicide. A lot of these drugs have a higher risk of suicide than others, but the medication guides are required for all antidepressants when they are being dispensed to patients. So the first drug class for antidepressants are selective serotonin reuptake inhibitors, also known as SSRIs, and they work by blocking the reuptake of serotonin. So, classic side effects for these particular class of drugs includes nausea and vomiting, dry mouth, drowsiness, headache, sexual dysfunction, and then something that we call serotonin syndrome. So serotonin syndrome occurs when drugs that increase serotonin levels are combined with drugs that themselves stimulate the serotonin receptors. So drugs that are designed to increase serotonin levels are combined with drugs that they themselves actually stimulate the production of serotonin. So it causes an overstimulation, and that's what they call a serotonin syndrome. It is rare, but it can be fatal, partly because it's so difficult to diagnose. Okay, so again, patients really wish that these antidepressants would work immediately, but that's not how they're designed. That's not how they're going to they're not going to work. Again, it takes about a full 4 weeks for these antidepressants to start taking effect, or to feel the full effect of what's going on. Antidepressants should also help these patients with any sleep issues that they are facing, and it just depends really on how their body is reacting to the medication. It's not uncommon for a patient to be prescribed, sertraline, which is Zoloft, and they start off with a 25 milligram dose for 3 to 4 weeks, and at that 4-week marker they're reevaluated to see how it's working, and if they're not getting that desired effect, they bump them up to a 50 milligram dose, and they can continue to go from there. So on slide 8, it gives you the different examples of SSRI. So things like Prozac, Celexa, Lexapro, Zoloft, Paxil. Those are very common antidepressant drugs. You see lots and lots of commercials on them. And again, if you look at the cautions and considerations with these drugs on this particular slide, it says increased risk of suicide. So Serotonin and norepinephrine reuptake inhibitors known as SNRIs. They block both the reuptake of serotonin and norepinephrine. They have pretty much kind of the same side effects: nausea, vomiting, drowsiness, but Cymbalta would be an example of an SNRI. So with Cymbalta, the drug is working to block both the reuptake of serotonin and the neurotransmitter norepinephrine, whereas the SSRIs are just blocking the reuptake of serotonin. So some of the drugs in this category on slide 10, again, Cymbalta, Effexor, Pristiq, commercials you've seen for them. Most of these have the caution, again, of an increased risk of suicide. Some antidepressants are not allowed to be prescribed in children or adolescents under the age of 18 because they are even at greater risk with some of these drugs for an increased risk of suicide. So tricyclic antidepressants, known as TCAs, they actually get their name because their chemical structures are like three rings. So that's where the tricyclic comes into play. So again, tricyclic antidepressants are named from their chemical structure of 3 rings. We refer to them as TCAs. They're used for 2 different things. One is the depression, which is why they're prescribed probably mostly, but it can also be prescribed for bedwetting. Examples would be amitriptyline, doxepin, imperamine, nortriptyline, increased risk of suicide in children and adolescents, and it's not to be used in patients that have any underlying heart conditions. Overdose of these actually can be fatal. Tetracyclic antidepressant, so they block the receptor that normally inhibit the release of serotonin and norepinephrine. So instead of blocking the reuptake, tetracyclic antidepressants actually block the receptors that release serotonin and norepinephrine. MAOIs, monoamine oxidase inhibitors, they inhibit the activity of the enzyme that breaks down catecholamines, resulting in a higher neurotransmitter levels in the synapse. So it's helping with the firing of the neurotransmitters through the nerve system and how those are delivered throughout the body. It is used for atypical depression, side effects, weight gain, edema. Again, watching closely for serotonin syndrome with these drugs. There is an increased risk of suicide, and MAOIs tend to interact with a lot of other prescription medications, so that's why they're not used as commonly, because they have a lot of drug-drug interactions. Other antidepressants, so bupropion or Wellbutrin. This blocks the reuptake of dopamine and norepinephrine. This one is used frequently for seasonal affective disorder. And one other use that a lot of people don't realize that they use for Wellbutrin is actually as a smoking cessation. So when people smoke, the nicotine fuels the dopamine, which is the feel good, right? They kind of get that euphoric. It's where the addiction piece comes from. So because it's blocking the reuptake of that dopamine, it's actually been successful in helping people quit smoking. Again, increased risk of suicide. Trazodone. Trazodone is used for depression. I've also seen it prescribed in a psychiatric setting for sleep. It helps to prevent the reuptake of serotonin and norepinephrine. It does have drowsiness, so that's one of the reasons why I've seen them use it in a psychiatric facility to help people sleep. It should not be used in young adults, children and adolescents because of the risk of serotonin syndrome, also the increased risk of different heart arrhythmias, and then the increased risk of suicide. So this is just a little short first part to kind of get you introduced to Chapter 7. So we reviewed from the beginning to slide 14. That's all you're responsible for today. Also reading, so your chapter reading is going to be from page 207 to 213, and then complete your daily assignment. Okay, so next week we're going to dive a little bit further into the psychiatric meds, and we will just continue on from there. If you have any questions, my phone number's on. Everything is listed under the instructor tab on Blackboard. I put it in the announcements. I've sent it into emails. So if you have questions, you can text or call me. If you text me, just make sure you tell me who you are. If you call me, obviously I'll be talking to you, and then in an email. Either way, that's my job. I'm here to help you. We're going to get through this. And Monday through Friday, 8 to 5. I usually answer after 5 if you know me very well. And I will answer on the weekends. So if you need me, get a hold of me, okay?